Great. Hi, everybody. Hopefully you can hear me. And I'm going to do my best. I'm recovering from a cold, so I'm hoping my voice lasts through this whole presentation. Well, thank you to Samantha and Rachel, actually, for really sort of getting into state strategies of how to address health equity and disparities. I thought the presentations and discussion was fantastic. Thank you for having me here. It's good to see some familiar faces. Now that I'm at NASHB, I'm really happy to be back working with the states 24/7, as I did at the National Governors Association with a number of you. And so today, what I thought I would do is really talk a little bit more about what are the strategies specific to states? Where have we seen some promising practices? Where are there ideas on where you all can go next? I thought both Samantha and Rachel did a really good job sort of outlining here's where we know we had disparities and systemic racism before the pandemic. Here's what happened during the pandemic, and here's where we need to look for in the future, both at the federal level and starting the conversation on the state level. What I thought I could do in my presentation was just talk a little bit more about some of the efforts, especially during COVID-19, that states have undertaken, and some specific examples, and then really hope to have a discussion with all of you on your reactions and thoughts on where we can go next. Maybe next slide, please. So you've heard about NASHB. I'm my fourth week here as executive director. And so a lot of what I'm going to talk about today, not only is just what NASHB is working on, but really what I worked on with Duke Margolis and also what I worked on with the National Governors Association. There's been a continuum of sort of state efforts from the beginning of this pandemic to now, and I know will continue in the future. And, like Rachel, I just have to thank you for the efforts that you all have been undertaking at the state level. This has not been an easy year. It's been very challenging. States have had to be at the forefront of a response without, knowing what the best answer is, without knowing kind of where to go next, and really having to troubleshoot and try different strategies to try to get your arms around the pandemic. So I hope what we're in is now a true recovery phase, where we can continue to, get more people vaccinated, get sort of better control over, any potential outbreaks, but also really look more strategically at how we can address equity. I feel like, you all have been in just the response mode for quite a while now, of having to just, what is the next crisis? What do we have to do tomorrow? How do we really solve this? And I'm hoping that, with the federal funding and with sort of the case count going down, and although there's continued work on vaccinations, that you'll have sort of more bandwidth, frankly, to think about, okay, how can we look sort of longer term and strategically about how we get traction both within the recovery period and beyond on equity. Okay, next slide, please. So a couple of things, and a lot of this was talked about earlier about, where have there been state priorities for health equity? And I wanted to talk a little bit about, COVID-19 impact and response, and that will really be the bulk of the presentation and the specific state examples. But I also wanted to recognize, and Rachel did some of this already, where states had already been down this path before we had the pandemic, and where we hear about continued interest and a momentum, frankly, of really kind of diving back in and thinking about how we solve some of these disparities. So behavioral health and individual and collective trauma. So, I think we all know that this has been a difficult year. And frankly, when we think about what comes next, and how people coming out of this pandemic have, increased number of deaths from, opioid misuse, more mental health challenges, there really is going to need to be some thinking around how do we ensure that we have the right workforce, the right system in place, and the right access and support for individuals, Medicaid program and beyond. So I think within that, there's also been, I think, a disparate impact on communities of color in both of those buckets. And so consideration of how we improve upon that, I think, is really key. I think the next area related to this is the opioid epidemic and opioid settlement. So again, as I mentioned, substance use disorder deaths on the rise, unfortunately, and there is settlement money now coming into the states. And how do we think about, that funding, not only just, addressing the public health system at large, but with an equity lens? And how do we really think about how that can be effective in targeting investments? Maternal health, I thought Rachel did a really nice job talking about maternal mortality and, the disparate impact on communities of color, particularly the Black community. This was certainly some work when I was at the National Governors Association where we were really getting into right before COVID-19. And I have to say, just from my perspective, there was a little bit of a pause on it because of the immediacy of the pandemic. And now we're seeing interest again in trying to re-engage and really get some traction, momentum around some of the work that was happening before the pandemic and where we can go now to really address disparities. And I think the interest from the federal level of moving on this will be really important. Social determinants of health. So I think there's a lot of things to talk about here with respect to equity and some specific work that states are now engaging in, at least, where we're working on from the NASHB perspective. Health and housing, I think, is a topic of interest where there's really been, and we're working with a community of 5 states on this, where there's been a real interest in how do we think about the investments coming, the federal funding coming, as well as braiding and blending funding that we already have at the state level to really make those investments in housing. There was, of course, a number of people who did not fare well during the pandemic, and there has been in some communities an increase in housing insecurity, and we all know housing is a real important determinant of health. So how do we think about that holistically is just one example, and especially with communities of color, because there has been data that we've seen that has really had a disparate impact on those populations. I think other areas that we touched on was the criminal justice system and thinking about how to get those services to those coming in and out of incarceration. And, I really appreciate the conversation with Florida as an example. And, Florida doesn't have sort of the Medicaid coverage levers that other states do because that state hasn't expanded Medicaid yet. And so the question is, for those states, what are their options for really addressing how to get services to those coming in and out of prisons? Now, there is federal dollars, although it's time limited, and where are the investments that make most sense? And then Medicaid and managed care, which also touched upon this as well, so I won't go into great detail here, but payment and delivery models, I think, are on the rise. There was some really good work earlier on before the pandemic in states like Michigan, where they have really spent a lot of time coming up with how do we incentivize our health plans to actually do better with respect to equity, and how do we make sure that we're seeing the results of that? How do we hold them accountable? And that's not always easy to do. I think one of the challenges in talking to a number of states is how can we measure progress on this? That goes beyond, okay, we're reducing the number of cases, we're increasing the number of vaccinations. When we think more about sort of systemic disparities and thinking about addressing equity in a more holistic way, it's harder to measure that. So I do think, thinking about how you leverage health plans as a piece of that will be really important work. And I think having the federal government have an interest in Medicaid and beyond for payment and delivery models is a definite signal for states to think about what they may want to do in their own state with their own Medicaid programs. Okay, so I promised I'm going to spend a lot of time talking about COVID, although, I'll try to go through it quickly. And then, of course, I'm really interested in the discussion. So next slide, please. Okay, so this is just a little bit of a roadmap about what I'm going to talk about with equity in the COVID-19 response. The first one is about COVID-19 equity task forces. So I will talk a little bit about what that is. Then I'm going to talk a little bit about the collection, disaggregation, reporting of race and ethnicity data, which I think is really important for states to understand the baseline of where there are gaps and that this is not easy work. And I think states have really tried to invest a lot in improving the data, but I think a lot more work needs to be done here. Then I'll talk a little bit about testing PPE and contact tracing, just in terms of how states use data to actually inform some of these pieces during the COVID-19 response, and really we'll need to continue to do that, especially where there's populations that remain not vaccinated or harder to reach with vaccinations. And then COVID-19 vaccines, I think, as Rachel touched on, this has really been a place where equity has really come to the forefront, and I think has really triggered a national conversation around, how are we doing on equity with reporting of data, with actually efforts to engage the communities, And what my hope is, you know, a lot of the lessons that we've learned in the context of the vaccine effort for real equitable distribution can then be applied more broadly to other areas of, you know, improving healthcare more holistically. And then I did want to just spend a little bit of time. We already started talking about before this presentation about federal funding and how, you know, with the billions of dollars coming to you all, I think the challenge is going to be, first of all, everybody has an opinion on how you should spend it. I'm certainly hearing that, and I'm not even a state leader. And so I know you all are hearing from a lot of different people. And then the challenge for you all is the timing of it, because things, you know, in certain states have to move fairly quickly with the legislature actually signing off on how to spend the funding. And then the nature of the time limited investment. So, you know, where are you going to be able to make the best investments, knowing that these dollars aren't going to be there forever? And I think that's sometimes hard for those that are not within state government to fully appreciate. And I'll just say here at NASHB, I really am going to make it a priority to make sure that we're supporting you all at the state level, to share that message with the many people that are coming to us in CHG. I'm sure you'll feel this as well. Many people coming to us saying like, well, they should be spending it on this and this and that, and without really fully understanding, you know, state budgetary process and how that really has to work when you have time limited funds, and where investments, things like infrastructure, can work, and where, you know, longer term investments are more challenging when you're trying to hire a whole workforce and, you know, taking people off the wait list for home and community-based waivers and that sort of thing, because at the end of the funding stream, you'd be worried about, okay, what do we do next? So anyway, I think there's a lot to talk about there, and it's been really interesting to see the emerging plans on how to address equity, and I'm happy to share a few examples from that as well. Okay, so next slide, please. Okay, so COVID equity task forces. So again, I really think COVID-19 has really sort of shined the bright light on the disparities we already knew that existed. And you know, 29 states have created a task force office or advisory council for equity with various models. Some have been governor appointed, some have been legislatively mandated, some have been located with departments of health or existing minority health offices. And, you know, now that I'm here at NASHB, we're part of this project, but when I was at NGA, we kicked off a project really convening the equity task forces. And then I went to Duke Margolis, and I continued to be in the project, and now at NASHB, I'm continuing to be in the project. But this project is really about sharing the learnings from equity task forces and what they were trying to accomplish during the pandemic, what they still are, and what comes next. And so it's really interesting to see across the council delve into trying to address equity. And I think this is the hard part. You know, what are the strategies that are going to work to really address the disparities? This is not easy. This is not easy work. There's a lot of things to consider and a lot of challenges. So just to share what, you know, the councils did, they had recommendations for the state's testing, PPE, contact tracing, reopening, vaccine and recovery plans. And a lot of them were really instrumental in figuring out how do we use sort of what we know on the data front to make sure we're driving the resources to the places and communities of color that need it the most. Support for communication efforts. They really are, you know, as Rachel talked about, you need sort of trusted messengers and thinking about how you really engage the community to make sure that they understand and are interested in receiving all of the support to address COVID-19. And so I think there was some really good work done on that front and continues to be in the vaccination effort. Making the connections with the community. I think a number of states have done this, even if they didn't have a task force, of really how do you invest in state-based organizations that have the connections with the communities of color, and how do you reach those in efforts such as the vaccine distribution effort, et cetera. Transparency and reporting for state activities during COVID-19. So, you know, I'll just talk about this briefly. You know, there has been now almost every state is reporting race and ethnicity data for vaccine distribution, for example. When we were starting this work back in February, not that many states were. And so there's definitely been an effort to try to get that information out so you can talk about the disparities. But there has been some real challenges with the quality of the data and the ability, for example, to understand the denominator. So not to go into a lot of detail on that, but, you know, do you use census data that may be 11 years old? Do you use the community access data that may not be, you know, not have the right subpopulations? You know, are the questions being asked differently at the state level, at the local level. So I think there's just been a number of different challenges on actually gathering this data. So I'll talk a little bit more about that in the vaccine effort piece. Okay, next slide, please. Oops. Next slide, please. Okay, there. Oh, uh-oh. Okay, so I want to talk just a little bit more about collecting and reporting race and ethnicity data to inform vaccine allocation distribution decisions. So the next couple slides are really going to be about sort of the vaccine effort and really trying to make sure we have equitable distribution. You know, publicly reporting race and ethnicity data to increase transparency, as I just talked about, has been somewhat challenging. I'll just identify a couple of state examples in case that's helpful. So New Mexico and Washington are examples of states that are publicly reporting race and ethnicity data by total population, percent partially vaccinated and percent fully vaccinated. And I know we have representative from Washington here, you know, in the discussion if she wants to expand upon that. That is, I think, not available for all states to do. And it's actually really helpful to see that breakdown to understand like where are there actual gaps. Virginia is a state that has developed dashboards to address this. Equity in action and equity at a glance. The Equity in Action dashboard is a snapshot of the progress that Virginia has made across the COVID-19 response and recovery programs to advance equitable distribution of resources and services. So this actually goes beyond just vaccines. It's also about, you know, their PPE efforts and making sure testing is available, et cetera. And the Equity at a Glance dashboard addresses social determinants of health and other factors contributing to health equity at the state and local level. So pending additional funding, you know, future versions of these dashboards may include an expanded set of topics such as workforce diversity, criminal justice, and law enforcement metrics, and cancer rates. So that's, I think, pretty interesting to watch. In March 2021, in Minnesota, the governor announced a partnership between the state and the Minnesota Electronic Health Record Consortium to publish vaccine data. And the reason I just highlight this is, you know, one of the challenges has been, you know, are vaccine providers asking the right question? Is there some feedback on my presentation when I'm talking? Okay, I'm going to try to.
There's quite a bit of feedback. I think every time you turn a page specifically.
Okay, all right, let me try to do that quietly. Thank you for telling me. So I was talking about Minnesota. So, you know, it's really sometimes challenging to collect the race and ethnicity data from the vaccine providers. They ask different questions. I think, you know, there has been some ways to try to incentivize that, and I'll talk about that in a minute. But Minnesota it was challenging trying to get that data into their IAS system, their immunization information system. And so using their electronic health record, the health systems that already had collected that data and had higher quality data like fed into the IAS, and then the state really beefed up their ability to report out race and ethnicity data. Just one example of like a public-private partnership, which I really think is could be key in really getting this data right. And another way to think about it is how do you create incentives for the vaccine providers to collect and report race and ethnicity data? North Carolina is a good example. They introduced an equity bump. So they were able to increase vaccine supply allotments for counties with larger historically marginalized populations. And they were requiring all their providers to report race and ethnicity data. And due in large part to that requirement and the reporting back to the providers to show when they weren't doing well, it's been successful. And they're actually one of the top states in terms of reporting the most complete race and ethnicity data on vaccines. So that was helpful. And then the third thing I want to talk about is how do you measure success? So certainly measure success by, you know, are the rates of vaccines improving upon in communities of color? Have the cases gone down, mortality rates gone down? I mean, those are going down across the country, but if you try to micro target and you have good data to know that, that's certainly one way. But I think some of the states that we've been talking to have really wanted to have a broader sort of success evaluation effort and thinking about how do we know that we're actually moving the needle on health equity. California Department of Public Health recently released a health equity metric to assign risk levels and assess reopening for a county by county level. not recently, they did this a little while ago. And I think they were trying to look beyond just, is there a lower case count and lower mortality rate, to really understand, are we making progress on, our equitable resources and focus on communities of color, and are we sort of turning the tide on COVID-19? Okay, next slide, please. I'll try to turn the page quietly. And then there's other different types of data that has been used by a number of different states, and we started talking about this already, and Norm was talking about this, Dr. Norman was talking about this in his remarks. So there's the CDC Social Vulnerability Index and census data to direct resources, and many states are using that to identify communities that really qualify for increased allocations. States, and this California, these are just examples. I think there's many other states, but California allocated 40% of all their vaccinations to 400 zip codes with high SVI that received less than 20% of total COVID-19 vaccines. Kansas earmarked vaccine supply for meatpacking workers. So lots of different ways to think about this. Connecticut has developed a targeted zip code dashboard, and each week publishes how vaccine providers are doing in vaccinating the populations living in those zip codes. Alaska's worked with communities to ensure clinic locations are available in neighborhoods with high SVI. Using the GIS mapping or zip codes to establish vaccination sites in or near communities. So that's another sort of data point to try to figure out where do you really need to focus. And Michigan is using a performance measure to track whether all residents are within a 20-minute drive to a COVID-19 vaccine site. Utah used zip codes that reflect communities with the greatest economic and social need to prioritize. So there's, I think, it's almost like mapping onto the Social Vulnerability Index, some geographic markers to make sure you're targeting the right places. Prioritizing equity-focused eligibility criteria to align to disease burden. So North Dakota is one example, and they used COVID-19 hospitalization rates, case rates, mortality rates, and SVI to prioritize communities and lower the age limit for American Indian individuals to 50 plus. This was earlier in the vaccine distribution effort. They found that to be very helpful. Rhode Island, also earlier in the vaccine effort, identified 7 zip codes with high density that represented 20% of the population, but 40% of COVID-19 hospitalizations. And the state reduced the age limit to 18 plus in one community, resulting in a 70% case rate reduction. So, I think all of these are tools that you all have used in the past number of months. And I think the reason I wanted to spend a little bit of time on this is, how do we think about using some of these resources moving forward? I keep talking about, and I'll get to the next slide and talk a little bit more strategies, but, COVID is going to now be a constant, not a crisis. There are going to be people who remain unvaccinated. You all at the state level are going to continue to be responsible to figure out, okay, can we just make sure that the case counts stay low? If there's an outbreak, we identify it, we move on it quickly. And using these data tools, I think, are going to be really useful in really identifying communities, in not just at the state level, but at the local level, to make sure that you're able to get the resources to those communities and identify who may still be transmitting the disease because they may not be vaccinated, or there may be some other type of outbreak. Okay, so next slide, please. So just a couple other things of really where states and a number of your states have done this. How do we really reach the communities of color in a way that's going to be effective? And so, going community by community is clearly where you all are going. The community-led mobile and pop-up vaccination clinics, not the mass vac sites, have proven to be kind of, where many states are moving. Reserving appointments for community-based organizations to make sure that they are able to register these individuals as a trusted resource. And in those instances, they've used community health workers and others that really were, trusted individuals for individuals who may not otherwise come in for a vaccine. Building on lessons learned and partnerships to develop to increase equitable access to COVID-19 testing. Some states have really used their testing networks to reduce or remove access barriers to vaccinations. And I will say, just on this note, especially for those populations that have not yet been vaccinated, testing continues to be necessary. And I think it's tough right now. And there's not a lot of, there's not that many people in those groups that are, actively seeking out testing. And so how do you, change the dialogue and continue to make testing available and have people understand why they need to get tested, especially if they haven't been vaccinated, to understand where there could be continued potential outbreaks of COVID-19. Removing requirements for proof of residency to remove fear. Those individuals that really are concerned around the government really taking action against them. You want them to be vaccinated. So what are the things you can do? And then increase funding and other supports to ensure transportation. Okay, next slide, please. And this is really, I think, the last one on the vaccines. Enabling community leadership and engagement to increase COVID-19 vaccine confidence and uptake. So I talked a little about this, increasing funding for trusted community leaders to lead community-based strategies and really directing, money to those community organizations. And here's just two examples. Rhode Island, they use their existing health equity zones, and the Department of Health directed $10 million to community-based COVID-19 response efforts. Massachusetts directed $1 million to the Massachusetts League of Community Health Centers to fund community-based organizations operating in 20 cities and towns with high COVID-19 burden. I know there's a lot more examples across the states. Oregon directed $9 million of CARES Act funding to more than 170 CBOs to provide culturally and linguistic accessible testing services and other related COVID-19 services. And they're using that to inform their COVID-19 vaccination efforts. And North Carolina has allocated $2.5 million to local transit authorities to offset the cost of helping people reach vaccination sites. So lots of different ways to do that. Providing clear and science-based information to support decision-making. Colorado partnered with trusted community organizations, including FQHC, CBOs, and faith-based organizations to hold weekly events. And, some of this I think is really about this is the challenging part. And this is why it's, the vaccination effort is slowing down. What voice resonates with the communities you're trying to reach? And it's going to be different in all the different locations. And figuring that out, so getting your arms around that, having the state play a role in that, I think is challenging work. And not everything is going to resonate with the same group. But for communities of color, these are some of the examples that states are utilizing. And then the last one is establishing multi-sector partnerships to bolster community-oriented strategies. And so Washington is just one example. They established a COVID-19 vaccine implementation collaborative to create a space for partners to build on existing efforts to prioritize communities who've experienced a disproportionate burden of COVID-19. Okay, next slide, please. All right, so I'm going to move on to a different topic. Adverse childhood experiences, trauma, and resilience. And the reason I wanted to just spend a minute talking about this is, of all the different areas where, I had been working on at NGA, when I was back at NGA before COVID-19, there were a lot of efforts that slowed down during the pandemic just because, resources had to be directed elsewhere. You had to address the COVID-19 pressing topic of the day. Adverse childhood experiences, at least, with the states we were working with at the time and continue to work with now, continue to have a lot of traction. And I think part of that is because, and we talked a little about this earlier, ACEs are not evenly distributed across all racial and ethnic groups. Black and Latinx children are more likely to experience ACEs, and the pandemic really exacerbated the risk of ACEs. And it's just, I think, a real concern about how do you all at the state level continue to prioritize identifying, addressing, and preventing ACEs during COVID-19 and centering universal healing during recovery efforts. I think there's a lot of interesting work going on now on ACEs if you're interested. Tennessee has had a cross executive, judicial, and legislative branch effort for a number of years now. If you're interested, I actually, we did a paper on that recently, and it's a resource that's linked at the end of this presentation of, what they're really able to do across all three systems. And I thought that would be particularly interesting to this group because you have all three represented here on your task force. I also want to mention California, ACEs Aware. They have really embarked on quite an ambitious goal of reducing ACEs by 50%. and they have really invested in having their Medicaid program cover both screening and services, have built an infrastructure around it, and a number of states are interested in learning more from them. And if you're interested, there's also going to be a case study coming out on California from NGA, Duke Margolis, and NASHB on that topic. So if that's something that's you're interested in, happy to follow up on that at a later date. Okay, next slide, please. Probably getting close to time. Okay, so, and I'll just quickly, so recovery and use of American Rescue Plan Act funds, and this is the part where you all started already talking about this. There's a lot of different ideas on how to invest these funds, and this list is really representative of what, governors, legislators have identified as areas where ARPA funds can be used to address equity. And so just wanted to share those with you. There's housing security, affordable housing, rental assistance, et cetera. There's food security, nutrition, supporting small businesses and BIPOC owned businesses, water, sewer, and broadband infrastructure, childcare and Head Start, behavioral health programs, addressing trauma and adverse childhood experiences, which we just talked about, addressing the domestic violence impacts of COVID-19, workforce development and education, and unemployment insurance benefits. So it's really a broad list. And, CSG, you're probably looking at this too. We're certainly trying to track that at NASHB of just understanding what's happening at the executive branch level and the legislative level of, where are things going. And I think states are at different places. Some states, their legislatures pretty close to already deciding or has already decided where some of the funds are going. In some states, that's still an open question. And so I really think the next number of months will be very informative as to, where these investments are going to be made and, what kind of flexibility you'll have over the next 2 years to figure out how to really target how you're going to use the funding. But I just did want to raise that for this conversation. Great, next slide, please. And the last thing I just wanted to say is I'm a person that's an optimist at heart. And I really think that we have an important moment now where there is federal funding flowing to the states. There is such an interest in equity because what we've seen with respect to the pandemic and so just what's happening across the country beyond that. And so really hoping that this moment can be leveraged to really address developing strategies to reduce disparities beyond COVID-19 and have more sustainable change that could be actually that we could actually experience over the next many years. I also think it's a time for creating more resilient public health systems, which will, with an equity lens, to make sure that we're addressing those populations, as Rachel said earlier, maybe more hesitant to engage with the system, and institutionalizing racial equity into governance and policy development. I did want to just note there have been a number of states where, there has been, DEI officers or cabinet level officials, like in Virginia, where there's an equity cabinet level official whose job it is to make sure that equity is infused across the agencies, so that making sure that, to my last point, we're centering diversity, equity, and inclusion in state government. And I think that kind of leadership is really needed to have a sustainable strategy and figure out kind of where the investment should be made over the next number of years. And with that, I will turn it back over to you, Carl, so we can have some questions and discussion.